keeping here. If you can please mute your phone, computer. Everyone should have been muted on entry, but if it comes off, please mute again. You can submit questions for the Q&A session in the chat, and we will go through those at the end of the session. And if you have any additional contacts, I am Tara from Katie, and you can contact me. My email is here. I will send the slides out after the meeting, so you'll have all this contact information. Just a little bit about my program. So I run the Central New Hampshire Community Opioid Response Program. It's a program of Katie. Our mission and vision are here. Our mission is that we aim to ensure comprehensive, coordinated, and easily accessible prevention, treatment, and recovery services for those impacted by opioid use disorders in the Central New Hampshire region. Our vision for the future is that we will build a community to prevent, treat, and promote recovery from opioid use disorders. This program will create a local system that is free of barriers, easily accessible, and fully integrated at every point of contact to reduce opioid misuse and promote healthy lifestyles and promising futures. We are made possible by a 3-year RCORP grant from the Health Resources and Services Administration, and my partners are Katy, Midstate, Spear, Park, and Lakes Region Mental Health Center. Our presenter today is Jeffrey Stewart. He's the founder and owner of Dragon Shield Consulting, interim president of the board of directors for the Capital Area Recovery Community Organization, and the chief of Brookline Ambulance Service. He's an accomplished healthcare executive with over 30 years of experience in all facets of hospital operations and emergency medical services, from practitioner to educator to leader. Jeffrey's proven record of operational success, team development, and problem solving is driven by his empathetic passion to assist and care for others, including patients, clients, colleagues, and the community. And I am going to stop sharing right there and welcome Jeffrey, and you should have capability to share your screen as well.
Excellent. Well, thank you all very much. I really appreciate it. Thank you to the community. Central New Hampshire community and the CAIDIA and all your sponsors. That's fantastic. I appreciate the opportunity to present. So let me see if I can get my screen shared. Click this to full screen and go to presentation. Can you all see my screen at this point?
Yes.
So I am going to be relying on Tara and Emily helping me, because as you can imagine, when we have 20 or 30 people in a room, it gets a little tough to manage the screening, the Snapchats, and the chat boxes. So as we go through, by all means, everyone's going to have opportunities to speak. We will, perhaps type your questions into the chat box. I do have it set up so that we will get some interaction and some conversations going. So that's kind of how we're going to run it today. I am going to be very cognizant, and if you see me looking up, it's because the way my office is set up, I have a big clock on the other side of the wall, so it keeps me in check if I yap too much. So I'm keeping my eye on that. So let's get in. Thank you very much for the intro. I've been doing emergency medical services since the 1980s. I started in the military as a medic, mostly in Central America. Very different perspective of the drug issues from the 1980s when I was running around Central America with some teams doing what we were doing. So to what we're dealing with today, it's a huge change in over 30 years. So in 1998, I started teaching about street drugs and designer drugs, and that was because our medical director, Dr. David Connor, at the time, who was my mentor, asked me, voluntold me to put together a Con Ed class on street drugs and designer drugs, and I see some smiles, so you all know the voluntold component, especially from your medical director. Yeah. So that went a little broad and unexpected, because at the time we had your typical drug classes. This is the drug, it's illegal, this is what it looks like, this is what it smells like, don't do it, don't touch it, you'll go to jail. And that was pretty much what we were seeing for education available. And what we did with Dr. Connor and myself is we changed this and made a very medically based here's the street drug, or here's the designer drug at the time. That's the terms we were using back then. And this is what it does to you medically. This is what the person using it wants to experience, but this is what you're going to experience from a medical perspective. And that blew up and went, really pushed me into this whole realm. In 2012, I actually became an official interventionist. So if any of you have seen the TV show 911 Intervention or Intervention 911, Ken Seeley's program, he does a great job. I am an interventionist, fully certified, credentialed. I've never had an intervention be as dramatic as you see it on TV. I've been yelled at, screamed at, lots of stomping feet, but no one has gone through a window, and I've never seen a TV thrown through a window, just saying. Although I appreciate Ken Seeley's program. I know him personally, and he does an excellent job with his intervention work. TV shows are TV shows. And I also opened Dragon Shield Consulting back then. Let me fix that. And then, of course, today I'm still a paramedic, still functioning as was mentioned earlier, and I am a recovery coach and a New Hampshire certified recovery support worker. So that's my background in a minute and a half. So let's get into what we're going to talk about today. Pretty straightforward. We're going to talk about the issue of mental health and substance use within our public safety professions. We're going to go over some terminology, and both from a mental health and substance use perspective, as well as the stigma associated with us in public safety. We're going to talk about the rescue personality, and that's something that, and again, I can't really survey our audience at this moment, but based on what I've been told, we have providers, we have law enforcement, we have healthcare workers, we have various public safety folks. We're going to define that group and what I mean by public safety in a second. But we're going to talk about some of that personality, that if you are a clinician or you're a supervisor of somebody or in charge of a group of public safety folks, how that impacts this perspective. And of course, today's purpose is to get a conversation going. So this is session 1. This is a 3-part series. Today, we're just laying down the groundwork and kind of giving us some structure to move forward. Session 2 and 3, we will get more into assessments and taking the temperature, for lack of a better word. Keep in mind, I come from the medical side of things. So we're going to take the pulse and we're going to take the temperature a lot of our staff. We're going to talk about that in our next sessions, and then how you actually intervene with a staff member, be it a peer, a colleague, or could be a subordinate, could also be a supervisor. And that can pose some challenges. And we'll talk about that a little bit in our next session. And then third session, we'll wrap up this whole perspective. So really the overall theme is to get you talking and to get you thinking and to get you interacting about this subject and taking care of our own, which is really what it's all about. So as we move forward, I want to make sure we're talking the same language. So when we say first responders, and you'll hear me use that term today, you hear it out in the public, I prefer public safety because that's really what we're talking about. But when I talk about first responders, here's what we're talking about, and here's the public safety group. You do not want to forget corrections officers. They are an integral component. They are public safety people. They are first responders, and they are part of this rescue personality that we will discuss shortly. The other thing that often gets overlooked is our emergency dispatchers, our communications. They're the voice on the end of the 911. And if you think about it from a mental health perspective, they're stuck at a desk. They're locked in. They have a job. They're good at their job. And they're hearing all this auditory input. Sometimes it's of the victims. Sometimes it's of the witnesses. And again, sometimes it's us when we get into trouble in the field, be it law enforcement, corrections, fire, it doesn't matter, any of us public safety, when we're out in the field, that connection, that dispatcher, that is our lifeline. And they're hearing all the stress, they're hearing all the trauma, and that has a significant impact. So I don't want us to forget our emergency communications people. EMS, Emergency Medical Services. Here in the state of New Hampshire, we utilize the National Registry standard. So we're emergency medical responder, EMT advanced, or paramedic. That's EMS. Fire service, pretty straightforward, our firefighters, and law enforcement. And again, when I say law enforcement, not just local police, don't forget our sheriffs are part of that, and some of our special police officers in the area wherever you happen to be. Lately, because I've been involved in Concord with some of the homeless operations and things going on, I've been working with some of the rail police. Sworn police officers have full authority within the state of New Hampshire, but often overlooked, yet they're smack in the middle of dealing with our substance use disorders and our homelessness, and they don't have necessarily a copious amount of training and frequently are forgotten a little bit when we talk about public safety as a whole. So this is the population that we're going to talk about for the next 3 sessions. There we go. So I was asked to, is there an issue? What's our epidemiology? Where is this coming from? I can attack it or I can approach this from 2 perspectives. I can cite specific cases here in the state of New Hampshire, but y'all can do that. I can cite you a ton of factoids, and I'm going to give you 1 slide on factoids in a second. But what I want to just kind of put in broad perspective, this is not unique to New Hampshire. This is a nationwide issue. There are tons of resources. So a quick Google search, firefighters' death by suicide. Notice I got 3.6 million results in less than half a second. If I change that up and put EMTs and alcohol abuse, 2.5 in just over half a second. Again, police officers' death by suicide, I got 88.6 in just over half a second. 911 operators, because I didn't want to forget our emergency communicators, and I put them with alcohol abuse, got 2.3. Again, just over half a second. First responders, remember that global term, public safety, those people I'm talking about, corrections officers, law enforcement, firefighters, EMS, emergency communicators. Death by suicide, 5 million in less than or at a half a second. And again, first responders with just alcohol abuse, 7.8 million responses in less than half a second. My purpose of this slide is we're limited in our time. I have less than 45 minutes to really get into the subject matter. If you want to do your own research, just kind of forewarn you, if you're doing a lit review, you've got plenty to choose from and to narrow down your searches. But there is copious opportunity out there. If I limit it to the state of New Hampshire, I have to be sensitive to who might be in our audience. And 2 weeks ago, we had another EMT here in the southern aspect of the state commit suicide. I did not know the individual. I ended up working with a couple of folks that worked with that individual. So it's here. I am aware of at least 7 public safety individuals that have died by their own hand, cause of death, suicide, since January. So that's 7 public safety right in here in New Hampshire that I'm aware of. That's not doing any deep dive. That's just 7 that I can name personally and I've had some interaction or work with. To kind of take it to the next level for those that like some facts, here's where I pulled some statistics. If you need to check my data, by all means. So I use the Center of Disease Control, I use the VA, I use the Department of Defense, the Public Health Network, and yes, there's an actual American Association of Suicidology. They do a ton of research and publish a lot on suicide in general. So those are some of the resources that I use when I pull this data and go into this statement here. So and I have to move your faces, there we go. When we talk about suicide as the cause of death, in the United States, it's the 10th leading cause of death. However, here in New Hampshire, it's the 8th leading cause of death. The national average is there's 12 deaths per day across the spectrum. And when I say the spectrum, I mean the demographics. So if we're talking adolescents, young adults, geriatric patients, African Americans, males versus females, Asian, doesn't matter, across your demographic mode, on average, 12 deaths per day in the United States. Men in the United States are 76.9 or 77% more likely to complete suicide. And women are 3 times more likely to attempt it than men. Again, not trying to be disrespectful in any way, that's just how the statistics come out. So in terms, if we were to get into a lengthy conversation, which we will not do today, about actual in-depth suicide issues, men tend to use more traumatic means, therefore they're more permanent. The women tend to do more pills and elongated mechanism of injury. Henceforth, there's more attempts than there are actual completions when it comes to this topic. Teenage attempts and completions are rising. That in New Hampshire, especially, we have seen a significant increase over the last 4 years with our teenage population that have attempted and completed suicide. So for us as public safety, we're the ones that are responding to these individuals. That takes a toll on us. The younger the patient, I'll tell you from direct experience, the younger the patient, the more it hits for me. The harder it is for me. I have no problem taking care of the patient and doing the job, but the more it sinks in my head over the weekend or when I'm off duty. So that definitely takes a toll on us, and that level is increasing here in New Hampshire specifically, but across the board as a nation, it is also increasing. Veteran suicide. This depends on which article or group that you talk to or where you pull your research. Generally speaking, it's accepted 18 to 22 per day. You hear most people now are settling in on the 22 per day. Different administrations impact the data that's put forward. When we look at veteran suicide specifically, keep in mind that's usually pulled from veterans that are connected to the VA. And I can tell you for a fact, not all veterans are connected to the VA. So we don't always have a really good number, but the general expectation is 18 to 22. And right now, most people and most agencies and authorities are settling in on the 22 per day as the number. First responder rates are increasing. As I said, I know personally of 7 here in New Hampshire since January. That's far too many as far as I'm concerned. 1's too many, but 7 strikes hard at the core. Out of this whole slide, if you take anything home, here's what I'd like you to take home. 10-22-5-1. 10th leading cause of death, 22 veterans per day, 5 first responders. And remember how we define first responders: corrections, dispatch, law enforcement, fire service, EMS. 5 per day. And then the one is actual active duty military personnel, 1 per day. So 10-22-5-1. That's the take-home message of our factoids. 10-22-5-1. 10th leading cause of death, 22 veterans per day, 5 first responders per day, and 1 active duty per day here in the United States. Those are staggering, and that's impactful. If you were to put that all together, that's 660 people a month. So something to think in. So I think I can comfortably say, yes, we have a problem. Let's talk a little bit about our rescue personality. The slide up there, that's for my communications, EMS, and fire staff. That picture probably gets you a little stimulated. Or if you're in management or supervision, you look at that and go, there's a lot of paperwork there. There's a lot of personnel to manage. But law enforcement, I didn't forget about you. Now to some younger law enforcement, that's exciting. To some of us supervisors, that can be awesome, good political capital. It's going to get me my budget next year. And then at some point, somebody had to count all that money, inventory all those leaves. And that guy is sitting there going, that's a lot of paperwork. So again, your perspective. So I'll just mash it all together, include everyone as we run through the rescue personality. This was first really published and studied with Mitchell and Bray. They were sociologists and sociologists and psychologists that did a huge amount of research on, at the time, they were looking in on fire and EMS and police. It was kind of focused on those 3. And then as their research accumulated and they were publishing, it really involves public safety and military personnel fall into this category. So if you want to do some extra reading or research, Mitchell and Bray, 1990 is when they published their first study. They've since published a few studies after that and a couple of good books on what the rescue personality is. So we're just going to run through that, because as we're going through this, I want you to picture yourself. I want you to picture your colleague or your supervisor or your subordinate, if you're in the higher echelon of management, one of your subordinates. The individual, we tend to be, and I say we because I fall into this, we are inner directed. I'll get it done. I'll do it. Not a problem. I can take on something and get something accomplished. And my motivation is internal. So it's an internal motivator. We are also incredibly action oriented. And again, that includes all public safety as I described, but we don't like to sit around a lot. We'd like to do things. And even when we're sitting around, we want to do something. You see us fidgeting, you see us playing cards, you see us doing some kind of training, you see physicality. You don't see a lot of just sitting around. Very action oriented at the core. Obsessed with high standards is an understatement. We pay attention to detail, and we do have high standards and high expectations of those performance standards. You know, through your entire career, no matter whether you go down the military route, law enforcement, corrections, EMS, fire standards, fire service, there's always a criteria, there's always a accomplishment, and you get scored and you get rated and are rated upon your performance. And that's an expectation of the career. And that is who we are and who we develop into. So we are obsessed with those performance standards. Traditional. Okay, for my fire audience, and I can't see all your faces, you know the saying, 100 years of tradition impeded by how much progress? Y'all can answer that. So we are very traditional, and we are loyal to our traditions, and we are proud of our traditions, and we motivate ourselves based on some of those traditions. And that again is instilled from very first day through your academy or your cadre, or your first EMS course, your first fire school cadre, whatever it might be. Those traditions start to get instilled in you right from the get-go. Generally speaking, socially conservative. I'm not trying to be political, but when it comes to folks who are of this mindset, they tend to be socially conservative. Independent thinkers, high on tradition, start to add all that up, high performance standards, they tend to be socially conservative. Not getting political in any way, shape, or form, but that's just the data has pushed out. Easily bored? Oh yeah. And if you're in any management, you get 2 or 3 or 4 staff in a room. If you're in police, depending on which public safety you're in, shenanigans will erupt. Not always in a bad way. It could be stress relief, could be pure entertainment, or the griping begins. So easily bored, they're either going to get in and do something, sometimes maliciously, not malicious, but more from a entertainment type perspective, or they're going to get into the griping and groaning. So we try to keep them busy and try to keep people busy. Highly dedicated, boy, dedication is an understatement. You can, and I see this in my military, I see this in all our public safety. I can take a group of military or a group of public safety and sit them down in a social environment, and they will banter and pick on each other unmercifully. But if somebody from the outside that's not part of that group then tries to chime in, that entire group turns the table and is very informative of that third party that you do not have that privilege to banter with us. We are highly dedicated to each other. We are highly dedicated to our professions. We will banter with each other in a pretty boisterous and aggressive movement, but we will defend our traditions and our service to the end. And that is a rescue personality. I go through this because this is what we're talking about. And as we start to move and look at our staff and our colleagues and our subordinates and our supervisors, and we look at them in the eyes of a crisis, we still have to deal with this personality. It still exists. And tradition, we're going to get into some of that stigma in a second. So I'm going to ask the audience, and you can type a couple in the chat section. Let's see if I can pull up the chat, or just unmute yourself for a moment and give me some terms that you think are stigmatizing in your respective positions. So ambulance driver, always a pet peeve with the EMS world. We'll tease each other about being ambulance drivers, but if somebody who's not in the profession, we're quick to correct them that we do more than that. Bedpan changer was something with my nursing staff. Hated that term. They'll pick on each other about it, but not let a third party. So what are some of the other stigmatizing language, if you guys want to just take a minute, unmute and fire some off? I'm hearing nothing. I'm hearing dead silence. You have to unmute if you're going to fire off anything. No one dares? I can't see the chat box, so I don't know if anyone put anything in the chat box. No. Okay. Well, that went over well. That's okay. I bet some. So a drunkard, a booze bag, stoner, pothead, junkie, addict. Those are all stigmatizing type terms. A nut job, they're weak. Subpar, that's an attack on our tradition and slam on high performance standards. Not up to speed, they're recycled. Our military personnel, you know what no-go stands for. So our no-goes, etc. That type of stigma language, again, builds upon, it hammers in tradition, and it prevents the individual who may need assistance from coming forward. And it can become part of your culture in your department and or your organization. So the goal, in either from a peer perspective or a leadership perspective, educational perspective, is to try to kind of keep an eye on what could be caused or what could be interpreted as stigmatizing. I'm not talking politically correct. Very, very different term here. I'm actually talking about things that can be constituted as stigmatizing. For example, if you are sitting around the coffee table or the coffee machine or the water bubbler at work in your station, etc., and you're talking about the quote nut job that you guys just took care of, either from an enforcement perspective or an emergency medical perspective, or even a fire call, you're referring to a patient, you're referring to somebody you've interacted with. That same context is reflected back within the job, because what if there's somebody else, what if somebody in your department or your colleague, what have you, is having some mental health issues? The perspective within the department is they're nut jobs and they're crazy. That's what we call them out on the street. Those are the people that we interact with. Well, that translates into the station and into the profession. If you're criticizing and having coffee talk banter about somebody who had to take a day off or took a week off to get some mental health stuff addressed, and you're using subpar, they're weak, they're not up to speed, they're just a no-go, then again, you're reinforcing that stigmatizing language. And we teach that as part of our traditions within the department. I'll give you an example. When I first started even military, my first suicide that I went on as a medic in the military, the sergeant, I was a private, I had the unfortunate job of the initial first responder at this scene. Regardless, the sergeants were telling me that's part of the job, and that guy wasn't fit to be in the Army, and he was weak, et cetera, et cetera. So this is 1985, 86. Today, we see it where, you know, if somebody's taking a anti-anxiety medication or a sleeping medication and or a antidepressant medication, they're looked upon as being weak. They can't handle the job. The old school traditions, when I became a civilian, it was if you had a bad call, this is how we handled it. And this is exactly how they handled it. Where I first worked as a paramedic, as a civilian, or as a full-time paid paramedic in Nashua, we'd have a bad call. We would get off shift. We'd go down to the local mini mart that had a breakfast, served breakfast. We had eggs and beer, because they started serving pitchers of beer at 7 a.m. And we would go down to that particular establishment. You would see the ambulance crew, you would see the engine crew, and then usually the police officer that was involved all come over, all sit down. We ate eggs, and really what we were doing, drinking beer. And suck it up, buttercup was the perspective. Then once you were done breakfast, now keep in mind, y'all just got off shift. You go home, shower, change, and you met up again around 1 in the afternoon for, quote, lunch, which was a continuation of the liquid libation and processing of the call. And that's how we dealt with it. I was taught that. We were taught that. And I know it wasn't just an EMS thing. For example, some of my very good friends that are firefighters, the old tradition of you're at your banquets, we hear the bell ring, we grab the shot glass, and we're ready, we're responding, we're putting out the fire's done, we put the unit back in service, and what I'm doing is I'm taking a shot. So they correlate the stages of responding to a call to the stages of consuming an alcohol shot, because the bell rang at the banquets. This is a tradition. So I'm not bashing the tradition. I'm using this to point out that this is back to that rescue personality. These are deep-seated traditions that we have to be cognizant of, and we have to start to correct as we move forward. And I'm watching my time, so I'm going to move on the stigmatizing component. Again, the purposes of today is to open up the door for conversation and to lay down some language that when we tackle session 2 and session 3, we're going to have some commonality. So there are options. The first thing you start with is an assessment. And when we talk about either mental health or substance use disorder, there's usually a peer assessment. And as a culture and a matter of policy and culture within a department, you can set this up so that everyone's kind of doing buddy checks on each other, or they're cognizant of it. And you can create that atmosphere where it's okay to step forward and say, hey, I think Jeff's having a hard time. Or I think Craig was having a hard time processing that call last night because that was tough. We haven't seen a SIDS case in quite a while. We did try to work that case and it did not come out well. Now, it's easy to relate those types of traumatic cases to the immediate EMTs and paramedics involved in the call. But don't forget, we had fire on scene, we had police on scene, and there's a good chance law enforcement was on scene before any of the police and fire, before any of the EMS or fire got on scene, as that law enforcement officer may have been on scene. And here in New Hampshire, we're technically a very rural state. So there's a high likelihood that a law enforcement officer was there on scene first. So just to keep that into perspective. So there's a peer assessment, a department and staff assessment. So you could assess individuals, you could assess your entire department or a group of your staff. And you can do that assessment from a mental health perspective, a substance use disorder. We would move them through. And then LOC, not loss of consciousness for my EMS folks in here. LOC is level of care. So if I'm working with a client and I'm doing an intervention or I'm setting up for an intervention and I'm starting to put together the pieces, I'm making a determination of whether I might be directing them down a mental health formality route or a substance use disorder formality route. Either way, I'm going to end up doing a level of care, and what level of care do they need? So that's just some of the assessment stuff. When we talk next session, we're going to talk about things that peer-to-peer assessments can do and how to do some interventions with that. I do want to put this in here because there's a distinct difference when we talk about suicide. And when I do my peer support group that I run, ideation is the thought of suicide. That doesn't mean somebody is suicidal. It just means that they periodically have thoughts of suicide. And if people are truly being honest in your group or amongst yourselves, if they've got more than 10 to 15 years, they've had those thoughts because either their particular situation directed those thoughts and or they came across some suicides and they had to process it that way. So ideation refers to thoughts of suicide. Doesn't mean they're suicidal, just means they have those thoughts. Suicidal threats, either verbal or actual. I'm going to kill myself. I'm going to shoot myself. I'm going to take these drugs and go to sleep and never wake up. Those are threats of suicide. Attempts are exactly that. an actual attempt. They did take those pills. They did cut themselves. They did try to hang from the tree. They put the loaded weapon in their mouth. Those types of things. Those are threats. And then, or excuse me, those are attempts. And then I do want to differentiate self-harm. There is a group of people, a level of care, but there's a group of people that are not suicidal, but they do self-harm. And when I'm talking about self-harm, I find this group fascinating when I do my work with them. They will intentionally hurt themselves, usually with cuts or pinches. Sometimes it's burns. They do not want to die. There is no suicidal ideation associated with this, but in their mental process, the actual infliction of pain, which medically speaking causes endorphin release and epinephrine and all that stuff, the infliction of pain causes a neurochemical release in their body, and they feel relief of stress from the infliction of pain from a self-harming perspective. The other descriptor they have with it is when they're cutters, the visual sight of the bleeding in their perspective is the pain or stress leaving their body. So they're self-harmers. Cutters, you see them frequently, burners, those types of patients that literally cut themselves, not for suicidal ideation, not for the purposes of death, but as a relief of stress or relief of pain. And it's an interesting group. I do a class when I teach suicide, we get into this a little bit, because often first responders, public safety, we misinterpret it. We misinterpret self-harming as suicidal ideations or threats or attempts, and it's not. It's a very different class of mental health person, and something we need to be cognizant of. Next, so we have assessments, and then we get into withdrawal management. Now, withdrawal management, old term, detox, that's what it was, detox, and it's really directed at our substance use disorder population. Now, IP, which is inpatient treatment, that can be mental health, that can be substance use disorder, either or. So IP is inpatient. PHP is partial hospitalization. So inpatient's obvious, you're in a hospital, you're getting your treatment, you're living there. PHP, you're going to therapy or you're going to the hospital at least 4 hours a day, 3 days a week. So you're getting a minimum of 12 hours per week of therapy. And that's considered a PHP. Not all people live at the hospital when they go through that. They're usually at home or they're in a boarding home. And that can be both for substance use disorder and mental health, both patients, both categories. Then there's IOP, which is intensive outpatient. Next level down from PHP. And this is at least 3 hours a day, 3 days a week. So that's at least 9 hours a week of therapy. Your standard OP, which is just outpatient, that's your standard. I go see a therapist once a week. Technically it's 50 minutes, and then the therapist gets 10 minutes to do their notes. From a billing perspective, that's how that works. So it's a 1 hour session. It's technically 50-minute session, usually 1 day a week. Now, support groups. I want to talk about those for a little bit. There are all kinds. There's a support group for anything and everything. They tend to be peer-led. For us as public safety, there are a few. They're often called badge meetings or public safety meetings or first responder meetings. And the difference is they tend to be usually the people are vetted. So whoever's running that meeting will vet the attendees. So there's a level of safety and security for us that go to those types of meetings, as opposed to the general public ones of like AA, Alcoholics Anonymous, NA, narcotics, Learn to Cope, Smart Recovery. There's a whole bunch out there. They're not all substance use disorder. I just listed some substance use disorder. But a lot of times the peer support groups, especially for public safety, are public safety folks. The one I run is on Thursday nights. It's open to any public safety person. They have to call me. I will vet them. So I'll vet them through fire, EMS, law enforcement, corrections, whatever the case might be. So I know for a fact that they are truly public safety members. We run a very open, any topic. We do a check-in and then we run a topic for the night, but we can talk about anything that's on their mind. No judgments, judgment-free zone. Everything is confidential unless there's an actual threat of suicide or homicide. And then we're legally obligated, as you all know, as public safety folks, to take action. We're obligated under regulations, be it law enforcement, fire service, EMS, corrections, it doesn't matter. Even 911 operators, we're obligated. All of these, be it mental health realm or substance use disorder realm, require some kind of a medical necessity. So often on the back of your insurance card, there's a 1-800 number. You call, you run through a quick little thing, and they recommend their treatment. I do want to mention, because this is a frustration level for public safety, I sit on the New Hampshire Senate commissions to study PTSD and suicide amongst first responders. This was something that we discovered. Well, I knew about it from substance use disorder in the public, and this is how we dealt with it on the New Hampshire workers' compensation perspective. Insurance companies, they don't like this term first fail. I call it right out the way I see it. It's called it's a first fail policy. They hate it when I call them out on it. They don't like that. It's not nice, but it's what's happening. They want you to use the least or the least cost approach. So if you have a substance use disorder, they would rather that you try an outpatient program first. They'd like you to try outpatient a couple of times. And then eventually they might agree with a inpatient program. And I call it the first fail because that's what happens. The person fails on outpatient treatment 2, 3, 4 times before the insurance company authorizes an inpatient placement. Insurance companies don't like me calling it what it is, but I have no problem calling it what it is. I've sat on many utilization reviews and insurance battles when we've tried to get people coverage. And that happens on both the mental health and physical health. Most insurance companies, private or public, doesn't matter, are extremely good on withdrawal management. They're quick and they're good at approval of that. It's the after withdrawal management that they run into problems. And in the mental health side, it's very hard. It's hard to get somebody truly placed inpatient for mental health because of the insurance challenges. So why do I tell you that? Because if your supervisors and your leaders out there, you might run into this if you're trying to help somebody get through the workers' comp process. We have done on the Senate Commission, we've changed some of the rules, we've expanded it a little bit. Post-traumatic stress disorder was always covered, but it wasn't clear in the form and or in the regs. That has been cleared up. There's also a thing called ASC, which is the acute stress disorder, ASD. 2 different levels of care, and we've helped to do some of that. So that's some good work that the Senate Commission did. So open discussion for about 10 or so minutes, 10, 15 minutes. This is where I'm going to rely on our assistants with Tara and Emily to help me manage this process here, because I can only see a few faces at a time. I ask that you would either unmute and or utilize utilize the chat box. I do have 2 more slides. We're not done yet. And yes, you do have homework, because it wouldn't be me if I didn't give some kind of homework. Come on. Those that know me, you know I'm going to give you a little. But it's good stuff. It's easy stuff. Nothing stressful. Too much. So questions, discussion. I was told I wanted to make sure I had enough time here for questions and comments.
Let me start.
Sure.
Volunteer squads are different than professional ones, but we still see the same things. How's that different coverage-wise?
In terms of what? Insurance or coverage in terms of?
Thinking about, well, insurance, but what would cover if people are having emotional problems or problems processing things? And we do our debriefings, but if you go further, you don't have an organization or a company behind you.
Right. So a lot of times it's left to the individual's healthcare and health insurance, whatever they have. And again, that's why I always say, if you flip over that health insurance card, there is those 1-800 numbers right on the back. If you were in a real rural, because I'm from Franconia, fair disclosure, consider Franconia my home. So it was all volunteer up there when I first got out of the military. If you live in those more rural areas where there might not be an employment or an insurance opportunity, we do have the New Hampshire Medicaid system, and I will give I got to give a little credit to the New Hampshire Medicaid system. They're pretty good at getting people on it pretty quickly. Usually within 48 to 72 hours, we can get somebody covered under the Medicaid system in New Hampshire. That does provide, depending on which carrier they use, there's 3 carriers in the state of New Hampshire under Medicaid. Each one carries the minimum, that's a requirement by the state, and then they each have their own added components. So there is treatment options there if needed. So I would refer them to their own personal insurance. If they don't have it, we'd work with them to get them on a Medicaid application. And then of course, if it is truly job related, even if you are a volunteer service, there is a liability coverage there with that town and or 501c3, depending on how your organization is set up. But that could be something you might have to explore at your specific department level. That answer it?
Yes, thank you.
You're welcome. First one's off. Pressure's on.
There is a question in the chat. Do private companies have an EAP usually?
Excellent question. Many do, not all of them. We're going to talk about EAP in about 5 minutes, briefly. But many do, and quite often it's through, believe it or not, it's through their life insurance provider, which is interesting. But again, many privates do. You might have to ask a little bit.
I think that's all I have.
Jeffrey.
Yes, sir.
Craig Clow.
Hi, Craig.
Hi. One thing that I've actually had a couple discussions recently with some of the outlying areas where they might not, not necessarily the volley squads, but smaller departments and services and stuff like that. They're going for assistance more so as a service rather than the individual, but at least going through their medical resource hospitals. I guess some of the medical resource hospitals that oversee these services, specifically for EMS, but fire departments as well, because a lot of fire departments will go through their medical resource hospitals. So that hospital that oversees them, if something were to happen, to get assistance, and they will plug into the hospital's human resources and employee assistance program to get them help. And if it's something that would require one-on-one stuff more so, then they would be able to refer them, try to work out the logistics on the cost of that. So that's another avenue to go down, or that I've been discussing with other services that to go down.
Right, you're cutting out a little bit, Craig, but I think I got the gist. So again, on the EMS side, so even if your fire department or police department provides emergency medical services, you have to have an affiliation agreement with a resource hospital here in New Hampshire, and that might be an opportunity to explore, at least on the initial criteria or the initial assessment, maybe utilizing the hospital's EAP program for that initial referral. Absolutely, I love that idea for sure. And again, so for those that don't know, Craig's one of those hospital area guys. So
three as of Friday, by the way.
Oh, congratulations! Or
condolences.
Anyone else? Excellent.
I have another chat box. If we have a suspicion that someone is having an issue, should they approach the person or wait for them to ask for help or someone to talk to?
Right. So we are definitely doing that next session. So I don't want to steal the next session. So I want you to come in, but in fairness, if you suspect, confront. And when you confront, I say confront because we're public safety. So bad choice of words. My physician, my mental health medical director would not like me to use that word, but I'm going to in this group. So when you approach them, you want to have your eggs in a row. We're going to talk a little bit of what eggs in your basket do you want to have when you approach them, but go ahead and initiate. And I just want to dispel right now, if you ask somebody, do they want to kill themselves? Are they suicidal? Are they thinking about killing themselves? You are not putting the idea in their head. Let me dispel that rumor right now. That is a bogus, old school, stigmatizing garbage rumor. Doesn't exist. If you're thinking somebody's suicidal, ask them. You're not putting the idea in their head. And we're really going to talk about that next session. So I don't want to give too much away. Anything else? No? Okay, I'm gonna move on. Just want to make sure. Don't hesitate. I'll give you contact info in a second. We did that, we did that, we did that, move that. So some final thoughts. So it really boils down to, and again, this session is to lay some groundwork for y'all and to lay some questions out. I'm not here to provide tons of answers in session 1. I really want you to kind of think about it and be ready session 2 so we can talk some more. But it does boil down to an awareness and a culture, and that's 2 things. You need to be aware of the problems, you need to be aware of the potential problems, and then you got to create that culture that where it's okay to bring some of those concerns forward and or seek that help. Watch out for that stigmatizing language. Peers are the key here. Peers, peers, peers. But I'm not going to let off our supervisors and managements. Make sure that they're supporting, whether you call them SOPs, SOGs, P&Ps, it's whatever you call them, standard operating procedures, standard operating guidelines, policies and procedures, whatever that is, take a look at those. And there's a reason I mentioned them tonight in 1 second. If you're the supervisor, you control some of that culture. Be cognizant of the rescue personality. We're keen on tradition, but sometimes some of our traditions are detrimental. You know, mass trousers. EAP, that's the Employee Assistance Program. Many, many private organizations, and in some cases municipalities, and as Craig pointed out, some of your medical resource hospitals have an EAP program. The EAP is great because of 2 things. 1, they can help a little bit with that initial debrief and kind of a check and balance. But what they're awesome at is referral, referral, referral. They're supposed to know the local agencies. They're supposed to know the local resources. That's their job, is to be able to sit there and they'll give you some tools for that immediate, reducing of the temperature, that immediate pulse check, but then they're going to be quick to refer you out for additional help. So don't hesitate to utilize an EAP. Those are really good resources. Because I'm talking public safety, this is a problem that we're cognizant of in the state of New Hampshire. The Senate Commission has that I sit on, we've discussed this. We are going to continue to discuss it once we get rekindled for this current legislative session. We know that there is a lack of providers that can deal with public safety. And I want to put that out right away. Public safety, we are the ones that make the therapist cry. Because when you're sitting there on that one-on-one session, or even in a group session, and I've got a therapist who is not familiar with public safety and or military, and we unload and we open up, the stuff we have seen, the stuff that we have smelled, the stuff that we have tasted, the stuff that we have come across, put our hands in, had to do is horrible, and we do it regularly. So the average person maybe has to deal with a traumatic death once in their lifetime, maybe twice. That's a shift for us. That's part of what we do. And whether we're dispatch and we have to listen to the victim call or the witness call and they're screaming and they're irate, and we have to de-escalate them to get the information to send the help, or we're dispatch and we're coordinating the help, and then the officer or the firefighter or the EMT gets injured, or corrections officer. What if I'm dispatch inside the jail and I got a riot going on and I just had 2 of my corrections officers go down? I can't leave. I'm stuck behind this desk. I have to listen to all that trauma, right? So we're the ones that cause the therapist to cry. And in New Hampshire, we are short highly skilled numbers of clinicians that can deal with public safety. We're well aware of that. There are things coming down the pipe that we're trying to deal with. They're long-term solutions. They're not immediate short-term, but that is something to be cognizant of And, you know, buyer beware and due diligence if you're looking for a therapist. So I'll get off that soapbox. Oh, did I not mention awareness and culture? Yes, I did that on purpose. I can't get this across enough in a 1-hour session. As a seasoned employee, as a supervisor, as a manager, as a director, as a chief, lieutenant, battalion chief, deputy chief, whatever your titles are, we are responsible for the culture. And we can't be taking in these 18, 19, 20, 21, 22-year-olds into our profession that we want them to be in for 20 years and look at them and say, suck it up, buttercup, this is the job, or get out. Because that's going to shoot us in the foot. Now, I can say that confidently because that was told to me. I may have early in my career said that to a few other people before I got smart enough. And I'm still not smart, but before I learned some stuff. And I need people to come into this profession because I am going to be that nasty curmudgeon, you know, 80-year-old calling 911 all the time going, I used to do your job, Sonny, come get me, right? That's my fantasy. No, I'm just kidding. So we want to make sure that those youngins coming up, whether they're coming up from law enforcement, fire service, EMS, corrections, or dispatch, however they're coming up, they got to come up with some resources and some resilience. And that's part of our job to change that culture and awareness. So homework, I promised, and I'm watching my time. I got 5 minutes left. Here's the thing. Go back to your stations. Go back to your bases. I just got to move your faces for a second. There we go. Walk through your station and look around for stigmatizing flyers, memos, posters, and be prepared to share some of those examples. They're there. Take a look. Take a second look. I'm not talking political correctness. That's not what I'm talking about. I'm talking about something that would make the junior EMT, paramedic, firefighter, police officer, corrections officer, dispatcher, the youngin, the new one, that would make them not seek help. So what's the tone? What's the message? What's there? Take a walk through your stations. Take a walk through your area. You'd be surprised what you might see. That's one. Second assignment. My question is, does your agency or department have an EAP program? If so, is the contact information readily available? And does the staff know how to do it? Right? EAP is confidential. So as a supervisor, if I had an employee that I was really worried about, or a staff member or a volunteer, I can require them to go to EAP. But I cannot require to know what the subject matter was. All I'll get back from the EAP person is, yep, Jeff showed up. That's all I needed to know. I don't need to know what he talked about. I don't need to know what you guys did or what your referrals were. I just need, did he or she show up? Yes, that's all. So you have an opportunity as a supervisor that you could require it, but we don't want to get there. It should be readily available. It should be all over the place. And do you have those opportunities? So that's your homework assignment. One of those two things. I hope to see you next week. Here is our next session. Let me get your faces out of the way. So our next session, June 16th, it's on recognition and intervention. So we're going to talk about barriers. We're going to talk about the ProQL and the LSI assessment tools that you guys can implement and modify with your own systems. We're going to talk about intervention methods. So how do you actually confront somebody, or I say confront, my medical director doesn't like me using that term, but how do you address somebody who you think is worried? And we'll get into that in our next session. CEUs for this session, there's a feedback form. Tara, how does that work?
Yep. So I just put the link for the evaluation in the chat box. I can also send it out via email. Oh, well, I'm not sure if I'll get the attendee on email, but yeah, let me look into that. If you need it and you can't get it out of the chat box, just shoot me an email. You all have my emails.
Yep.
That'll probably
And
be the best way.
there's my contact information email and my cell phone. That cell phone is 24/7, except in 2 cases. If I'm working with a client or patient, I won't answer it. It'll go to voicemail. And if I'm on my motorcycle, I won't answer it. State troopers, I love them. They're great guys, but they hate it when I go down the highway at 80 miles an hour yapping on my cell phone. So I'll let it go to voicemail and I'll call you back, guaranteed. Anything else? Any other questions? We have 1 minute, 2 minutes left. I did that right.
Yeah, perfect. Right on time.
Thank you all very much. I really appreciate it. Hit me up with any questions, comments, complaints, or concerns.
Thank you, everybody. So yes, get that evaluation filled out, especially if you're applying for CEUs. And let me know if you have any questions, and we will see you on June 16th. And don't forget to do your homework.
Thank you all very much. Have a great day.
Have a great day.
Thanks.